So this is going to be an example of what we're thinking about for the expert tutorial video tour. So we're going to start with this gingival biopsy, starting at lower power, and you can see we have an infiltrate within the mucosa. Moving to higher power to get a better look at the cells. You can see the epithelium, and the infiltrate is predominantly in the mucosa, not infiltrating into the epithelium, although there's some raggedness at the basal epithelial border. So let's go to higher power, get a better look at these cells, and I'll get a little adjustment here, and we can see that there are, I'll use my mouse to see that there are plasma cells in this infiltrate as well as mononuclear cells, some a little larger with more open chromatin and small nucleoli, and smaller cells that are a bit more hyperchromatic. But we'll go to another higher power. Now we're at 40x to take a closer look at these cells. And we can appreciate more so their open chromatin and the nucleoli, although they're not macronucleoli, as well as we can see smaller cells and hyperchromatic lymphoid cells as well. So of course these mononuclear cells look lymphoid in appearance, some with round nuclear contours, some are irregular or elongate forms. And actually I've now moved to another area, and I'm going to fix the slide a little bit so we can see it more clearly. And we can see we have this diffuse infiltrate of intermediate to large size mononuclear cells. We'll go to a higher power again so we can see this infiltrate in another area. We can see the small nucleoli as well as some smaller hyperchromatic cells also admixed in. And so the idea would be at this point to have a discussion as far as what the differential might be, what things you'd be thinking about, what kind of panels you would be doing. And so in a case like this, this patient actually came in with a history of myeloma and got sent to us with a CD138 and wondering if there should be concern for plasma cell myeloma. We certainly do have plasma cells here, but that's not the most concerning component. And we would be considering other lymphoid neoplasms. In this site, certainly T and NK cell neoplasms would be of concern, but we couldn't exclude that we didn't have a B cell neoplasm as well. This is the CD138 highlighting the epithelium as well as the scattered plasma cells. Given that plasma cells can look like a variety of things, certainly would want to be sure that we didn't have some kind of an atypical look to the plasma cells, but this certainly does not express 138. CD20 just highlights rare positive B cells. The infiltrate is negative. And then looking at our CD3, and we have numerous positive cells. So the infiltrate, and there's just some artifact, some technical artifact there. Infiltrate is predominantly CD3 positive. We can go to higher power view, take a look at that as well. Can adjust the screen. Here is the CD7, and we can see the infiltrate is CD7 negative. The CD7 is only highlighting scattered T cells. This neoplasm was also positive for CD2 and CD8 and lacked CD4 and CD5. With CD8 expression, we might be wondering about TIA1. And here's the TIA1 showing nice expression in this neoplasm, the nice dot-like positivity. We'll get that a little bit sharper. And then on everybody's mind now is EBV and CD56. So let's look at the CD56 first. And that is low power. We'll look at all three pieces here. We're seeing some variable expression. the CD56 expression. So not all of the cells are positive for CD56, showing variable expression, but we did have nice TIA1. So let's take a look at the EBER, which shows nice nuclear expression in this neoplasm. Given that we did have CD8 expression, that would make it unlikely that it is NK cell, but we also did a beta F1, which is positive, and therefore this is an extranodal NK T cell lymphoma nasal type, given that it is beta F1 positive. This is T lineage as opposed to NK. Thanks.